Out is really exciting. Welcome to our Patient Safety Conference. This is a joint conference between the Department of Medicine, Nursing, and Pharmacy, so thank you all so much for being here. Thank you, Dr. Keys, for the cookies. And also, this conference will provide CME and the equivalent nursing continuing education credit, so please make sure you've signed in if you'd like to receive that credit. All right, so just as an introduction, the purpose of this conference, this is a conference that we have bi-monthly through the Department of Medicine. It's to create a forum in which members of a multidisciplinary healthcare team can engage in objective, non-judgmental review of adverse outcomes and commit to systematic process change. The guiding principles are to foster a safe, open, respectful environment that facilitates discussion, learning, and teamwork, to focus on systems factors as root causes of adverse events rather than individuals. So it's to look for underlying systems level causations that were manifest in personnel related performance issues. And all of what we talk about is confidential and privileged. So today we're actually going to do something a little bit different. We're going to talk about a case that occurred outside of our institution. A very tragic case that involved inadvertent administration of a paralytic to a non-intubated patient. This occurred at Vanderbilt University Medical Center in late 2017. And we're going to discuss this case because it made national news, because it was such a tragic and severe adverse event, but also because the caregiver at the sharp end of care, the nurse who gave the medication, was charged and subsequently indicted on reckless homicide charges. So this case made national news. I think there's a lot to talk about. It can also happen anywhere. So I think it's worth discussing how can we prevent this at our institution. So with that, I'm going to hand it over to the resident leaders for the conference. We also have leaders from nursing and pharmacy, and I'll let everyone just introduce themselves as they come up. All right, thank you.
Thanks, Dr. Wooten. I'm Hassan Shahid, one of the third-year residents, and I'm going to go over with the event timeline of this incident, and then I'm going to hand over the mic to Dr. Jones. So, as Dr. Wooten said, this was the case that wasn't that didn't happen here. It was from Vanderbilt University Medical Center. So. There was this lady, 75-year-old patient, who was admitted to Vanderbilt, and her diagnosis was IPH, or intraparenchymal hemorrhage, and she had homonymous hemianopia on the left side and headache. Now, we do not have all the information, just a disclaimer, because all the information from the case is coming from the CMS report, so there were some details that are missing, so just bear with that. So on 26th of December 2017, the patient was transported for PET scan. That was initially when she was admitted to neuro ICU and then went to step down, and then she was going for a PET scan. When she was going for PET scan, she was alert and oriented, and she requested something for anxiety. Now, we do not know why she was going for PET scan. Usually they do CT scan or MRI. We are not sure what happened. So what happened is at almost 2:45 p.m., 2 p.m., the radiology requested for something for the anxiety because the patient said she is claustrophobic. So she was going for a PET scan, so she was injected with a intravenous radio tracer, and she was supposed to wait for 1 hour in a waiting room, and then she was going for her scan. So she said she's claustrophobic and she needs something for anxiety, and radiology technician requested that from the nurse, and then a physician ordered 2 milligrams of Versed intravenous. At 2:49 p.m., the pharmacy verified the order, and radiology then called and asked the unit nurse to come and administer Versed, or patient would be sent back. And as we will see later, they had the reason. They were like, their schedule was full that day, and they had back-to-back cases and imaging scheduled, so they were kind of in a rush. So bedside nurse was busy, so a help all nurse was asked, and that's essentially the same thing as a float nurse that we have, a nurse who does not have any active patient care duty, but she is helping, or he or she is helping with the other nurses. At 3 p.m., 2:59, The nurse searched for Versed under the patient's profile in the ADC, like the Omnicell. She could not find it, so she just searched the entire ADC, like we can do in the Omnicell, and she just typed the first two letters of Versed, i.e., just V and E, and then she selected Vicuronium, which is a neuromuscular blocker, instead of Versed. And she pulled 10 milligrams of Vicuronium from the ADC, and she labeled and reconstituted the med. This medicine was taken to radiology, and it was unfortunately given to the patient. The nurse left, and the patient was unmonitored. So patient was not in the scan at that time. She had received the IV tracer. She was waiting for 1 hour in that in the waiting room, where there was a camera to monitor her, but there was no monitors hooked or anything because she wasn't in the scan. And it's according to the radiation tech that was there, and later his narrative, it said that you can see the patient on the camera, but it's like really not easy to tell if the patient had their eyes open or if they are in distress or anything. But apparently they saw that patient is not moving and they have stopped breathing. So around 3:45 p.m. code blue was called, and at that time patient was intubated. She had a couple of cycles of chest compressions, and then ROSC, or return of spontaneous circulation, was achieved, and the patient was sent back to the neuro ICU. Patient was later transitioned to comfort care because of very less neurological function recovery. Again, I'm not sure about the exact details, but the CMS, if you read the CMS report, it actually mentions that they discussed with the family, and the physicians also thought that she didn't have much chance of a viable recovery, so they transitioned to comfort care, and the patient soon passed after that. So basically, the one thing that happened is the patient received Vicuronium instead of Versed, and looks like that was the main reason for this patient's death. So the summary is that we had a 75-year-old hemodynamically stable patient who was requesting something for anxiety, and there was this nurse who was working as a help all role or float nurse with Oriente, and she reported not being familiar with patient or area of the hospital. And she was talking to the Oriente while at the ADC. While she was pulling the drug, she was talking to her Oriente, and hence she did not double check which medicine she had pulled. So the wrong medicine was pulled, which required several overrides. So just like we have seen here, we usually we do it all the time. Like we just click benefit outweigh risk or something, and we just override. So the same thing happened over there. So the initial order of Versed was reviewed by pharmacy, but then she override and searched it in whole of the ADC, and that was not reviewed by the pharmacy. And she was able to pull a neuromuscular blocker without additional warnings. So the patient was given this Vicuronium, and then she was left unmonitored. Essentially, there was a camera, and like the patient was on the camera, but it wasn't that good quality, and there was no active surveillance. So patient was not accompanied by anybody in that room. And the Versed was not on high-risk med list at that hospital. It was not one of the meds that required special monitoring. And patient was found pulseless, and code blue was called, ultimately transferred to ICU and passed within 24 hours, as I mentioned before. So that's a summary. Any questions so far pertinent to the case history or anything that you guys have? Again, we extracted all this data from the CMS case. So if you see this error categorizing wheel, it's actually a category 1 error, and as you can see, that's an error that may have contributed, category I, yeah, that may have contributed to or resulted in patient's death. And it's the last one. It's the most severe error that leads to patient's death. So the fallout in this case, the medical examiner's office was told that the patient died from bleeding and that any medication errors were purely hearsay. Medical examiner declined the case because it was felt the patient died of natural causes. But it looks like that wasn't the case because the patient was hemodynamically stable, alert-oriented ×3. She was able to talk, and she said she's anxious, she wants something. So, doesn't look like a natural cause or without any medication side effect. The nurse was fired, and subsequently she was indicted on reckless homicide charges. Board of Nursing did not take action against nurse's license, and Vanderbilt was subject to CMS investigation. So these are a couple of fallout. So from physician's perspective, the physician's consideration in whole of this case, one thing that we came up with that is Versed an appropriate medication for claustrophobia with PET scan? Because usually here we don't do that. We usually give Ativan for if somebody is anxious and if somebody is like on the is like elderly, or they have other risk factors for delirium like previous ICU stay or dementia or maybe bleed, IPH or something. We usually consider antipsychotics. So we don't know if Versed was an appropriate or approved medication used for sedation or for anxiolysis. And did the physician check for potential anxiety prior to procedure or imaging, as we usually get a message before sending a patient to CT scan or actually for MRI or PET scan, that does this patient need anesthesia or not? And if they need anesthesia, usually they get something with anesthetists. What is the hospital's policy for moderate sedation for procedures or imaging, if there is one, and what type of anxiolytics or sedatives can be used, and what is considered conscious sedation and what is considered moderate sedation? And then the last one, as I mentioned earlier, was the PET scan, the appropriate imaging study. Again, I'm not sure why a PET scan was chosen. Usually, we don't do PET scans in-house, so I'm not sure what was the reasoning. It looks like she had IPH. I'm not sure what they were trying to see, but we don't have the we don't have the whole records. So these are some of the physician considerations that we came up with, and now I'm gonna pass the mic on to Colby, and he's gonna talk about the nursing consideration.
So my name's Colby Napper. I'm a CSL for MI, CU, and WICU. So out of this case, these are the 4 things that I pulled out that I thought were the most important to consider. First, timeout with a provider at the bedside prior to the administration of any medication given for conscious or moderate sedation. The proper use of the 5 rights of medication administration. The proper monitoring of a patient's receiving sedation. And then look at the ability at the bedside nursing staff to override neuromuscular blockers and potential safeguards. So first, most importantly, a timeout. I know up in MICU, anytime we do a bedside procedure or we're getting ready to give anything that's going to sedate the patient, we do a verbal timeout before the administration of the medicine, just verifying with the physician we've got the right dose and what was ordered. Right here I've listed our policy here at Erlanger for procedural sedation given by a non-person out of anesthesiology. And I'll pull it up real quick because I just want to note something real quick. Right here where it says under safe administration requirements for moderate sedation, sedated patients shall not be left alone during and immediately after this sedation has been given. I'm not really sure why the patient was in a waiting room and given Versed in the first place. I know personally I would not feel comfortable giving anyone any type of sedation without a cardiac monitor hooked to them. And I do want to point out too, this policy has been revised and will be coming out again once it's approved, I think, by best practice. Next, your basic 5 rights of medication administration. These are the 5 basic things that we're taught at every nursing school. I know I teach a little bit on the side doing some adjunct work, and my students are always like, is this really important? Should we do these 5 steps every time? Yes. For this instance, just right here. Your right patient, your right dose, your right drug, right route, and right time. And I've cited here, this was actually first brought about by the Institute of Safe Medication Practices back in '91. Here I've listed the 2 medicines, just kind of comparing the 2. I pulled this from a Davis drug guide. So with Versed, you want to assess the level of sedation and level of consciousness throughout administration and 2 to 6 hours following administration. You want to monitor BP, pulse, respirations continuously during IV administration. You want to make sure oxygen and resuscitative equipment is immediately available there at the bedside. And then typically Versed is usually given for intubated patients or for moderate sedation where they're going to have continuous monitoring. Vecuronium, the drug that was given, you want to assess respiratory status throughout and continuously throughout therapy. You want to monitor EKG, heart rate, blood pressure throughout administration. Observe for any residual muscle weakness, respiratory distress during the recovery period. And before you give this drug, you should always be ready to facilitate intubation because you're essentially getting ready to paralyze the patient. Talking about overriding and safeguards, one thing I want to bring out, were there any safeguards in place prior to the administration of this medicine? Did the nurse get an alert this was a neuromuscular blocker? Did she get an alert saying what the drug was going to do to the patient when she gave it from their Omnicell cabinet or whatever they dispense from? And something else we should consider, should there be a policy written here at Erlanger for nurses overriding medications? Not every nurse can override any medication in an Omnicell cabinet. We've got several super users throughout the health system that can do this. But should we consider writing a policy of what medications we can override and what situations we should do that in?
My name is Brittany White, and I work with the clinical pharmacy department. I just want to go over some observations from our pharmacy staff on potential contributions to this error. The first one being, when you look at an automated dispensing cabinet, we have lots of guidelines in place from the Institute of Safe Medicine Practices that are implemented when we use automated dispensing cabinets like this. A few things we looked at were that there was failure to confirm that the nurse had the correct medication prior to administering the medication, and also failure to question the need for reconstitution of this drug. And so it's well known that midazolam or Versed does not require reconstitution. And so one would think that if we took the time to look on the label for the drug to determine how much volume was required for reconstitution, we should have also recognized different packaging and also need to reconstitute a drug that presumably a critical care nurse would have had to procure and administer in the past. Also, failure to scan the medication upon administration. And so even if this medication had been obtained via override, meaning when a medication is pulled on override, the pharmacy is not flagged to review that order. So something that's pulled on override should typically be done when a delay in obtaining that medication could result in patient harm. And so then the nurse or provider administering the medication can go back retrospectively and scan that vial or that packaging to make sure that what was pulled is actually what they meant to administer to the patient. Use of the override feature in a non-emergent case, I think, was a big pitfall here. Also, potentially failure to recognize anxiety or the claustrophobia history as maybe a potential barrier to having the procedure done in a timely manner. And so I would wonder if this patient was explained the procedure and what would be happening so that they could have circumvented that. And also failure to monitor the patient after administration of an IV sedative was a major problem.
I'm Jamie Jones. I'm one of the second-year internal medicine residents. So we've talked a lot about the case and all the different things that we've found, all the holes kind of things that we found that, what could have gone wrong, how did all these things accumulate and then cause the death of this patient. So we talk about accident causation, and then you can look at the person, so you can just focus on the person, the unsafe acts, their errors that they did, procedural violations,
all of these things. Is it from forgetfulness, inattention, carelessness, negligence? And then you look at the corrective actions. So how do you eliminate this unwanted behavior? Because humans are humans, we make mistakes all the time, so there should be systems in place to kind of help minimize these mistakes. So they say like naming, blaming, and shaming. So these are where new policies come in from these mistakes. Then you look at the systems approach, like I said, where humans make mistakes. So what can we do to facilitate and help our organization to prevent these mistakes from happening? So all these errors can be, you look at a person error, or you can look at a system failure. So these kind of look into both aspects of the error and see why they did and what corrective things we can do to improve these. So James Reason, he's a psychologist out of England. He's done a lot of research into this, and he's kind of came up with the Swiss cheese model. So you look at your organizational and corporate culture, you look at the management decisions, organizational processes, then you go into the contributory factors that influence your clinical practice, whether it's these errors or violations, and then the care management problems where you go more into the errors and violations, and then you have your defense barriers, and these are the things that should prevent the accident or incident from falling through. And then you can see that there's a little hole with the arrow going to the incident that goes through these defense barriers that get into it. So that's where this Swiss cheese model comes in, where Swiss cheese has all these holes in it, and once they line up, that's when the error calls. So it kind of makes you look into these things to see why it happened, whether it's a latent condition, like you already had a defect in the system, or an active failure where it's negligence or inattention that caused these. So he talks a lot about what is a just culture. So recognizes that individual practitioners should not be held accountable for system failings over which they have no control. But you have to also recognize the individual errors, that these can be predictable interactions between humans and systems in which they work. However, then you have to look at the no blame and say that, where does the blame fall? And then we'll go into the next slide that kind of walks you through an algorithm to kind of figure out, okay, is the person to blame for this, or is this a system failure, or is it a combination of them? So pretty much it's just saying, like a just culture, you recognize that you have these competent professionals, they make mistakes, you acknowledge that, but also there are these systems that also fail them as well. So this is kind of the algorithm where you kind of go through. So were the actions intended? In this case, no. She did not intend to do any harm. Was this an unauthorized substance? And what it means is not, was the person that made the error taking an unauthorized substance? In that case, no. Versed was authorized. It was ordered. However, the mistake was made that was not the correct medication. So did she knowingly violate safe operating procedures? No, she didn't. But then the question comes in with the substitution test. Would other people have made the same mistake if they were in her shoes? And I think that's the question. We found all of these flaws, like you had to reconstitute this medication. Surely you would have known, but this could have happened to someone else. So I think that's where trying to figure out what the appropriate error or appropriate punishment in this case kind of comes into play. So you have your three behaviors: the normal error, at-risk behavior, and then reckless behavior. And then these kind of go into how do you approach these situations and take the corrective action. So normal error, you manage these through your procedures, systems error, almost like a slip or a lapse, like a blameless error. It's not necessarily the person's fault because there are so many faults in the system. And then your at-risk is risk not recognized or believe that it's justified. So you do more training with your employees or whatnot, plus you look into the situation and systems. And then your reckless behavior is going to be that person just had disregard for the patient or for any policy or procedure and just completely remissed it. Now I'm going to hand it over to Dr. Stone.
Hey everybody, I'm Yarley Stone, one of the second-year medicine residents. So what we're going to do now is kind of everybody break off into 4 or 5 people sitting around you. You all should have gotten the fishbone diagram when you came in, and so working to figure out what sort of systems factors contribute to this case, and to kind of look at the big topics, and see if the next slide. So looking through these systems factors. So I don't have an example one here, but the big box at the top should be one of these things. Is it a patient factor? Is it a task factor? Provider factors? And then going down the list and breaking it down a little bit more and seeing, okay, what was it about the patient? What was it about the system in general? About the EMR that all helped contribute towards it. And then we'll go through kind of together once we have a couple minutes and everybody fills one out, and make one sort of as a group to see what systems factors help lead to this. So if we want to take the next 5 minutes and kind of talk with the people amongst yourselves, then we'll talk again here in a second. I'll leave this up for you guys so you can kind of base it off of these.
It's mainly Sam.
All right, everyone. If you could get with your group and select a representative and maybe your top 2 systems issues, and then we'll go around the room and share. All right. Do you want to do this too?
We have 3 mics, so
Okay.
we can have it run.
Yeah, perfect.
You gotta wait till they tell us the factor, and then, so I think this is 1, 2, 3, like under major.
I'll capture this back section.
I'll figure it out.
I think that's it.
Fall risk.
I didn't know.
Or
Oh, yeah, 'cause you can't put them on there. That's kind of what you're saying.
somebody twists their ankle, we can't afford to have any man down.
Or you can just fill out.
All right, let's start in the back. Anyone back here ready to share? Great.
Lots of questions. Okay, so we started with the patient.
Okay.
So we know that she was anxious, but did the physician ever go and actually look at her? Was this an order given over the phone for somebody that didn't know her? That was one of our big questions with that, is who looked at her. The next area is the task function. What are the sedation standards at the hospital? What level of training did the nurse have? And why did the float nurse go down versus the primary nurse? Like, to me, the float nurse is the person that's going to watch my patients when I have to leave the floor. So why did the primary nurse not go?
Yeah, we had the same sort of question when we were talking through it. Would that go, Dr. Wooden, would that go under task or provider, or where does that kind of?
It kind of goes everywhere for
Yeah.
me.
I think you could do either one.
Kind of either way, okay.
Yeah. Great. Excellent. Next.
After I figured out what happened,
Pass that. Oh, you got it? Okay.
So the systems issues that we identified is that there's no scanner available in outpatient radiology areas there, which I used to work there, so I actually know that for a fact, that there are not scanners available in the outpatient radiology areas.
I'd probably do that under local environment.
Under local environment? Cool.
Then one of the other questions that we had, and I don't know the answer to this, is that do they have a med alert that comes up when they pull a paralytic on their automated dispensing machine?
That's a really great idea. Hold on to that thought. All right. Anyone else over here? Okay. You guys in the back? Do you want to share?
I think it's an issue with warning fatigue. If the warning did pop up and she ignored it, it should be a better way of making sure that doesn't happen.
Okay, great. It's maybe under EMR. All right. Who's next? Anybody want to share back here?
We had a question about the training and education. We weren't sure if maybe this nurse wasn't familiar in the area. Maybe she didn't know to question a Versed order. She had never pulled it before, or she didn't know the difference between the two drugs. And so she didn't know to question it, or when she had to reconstitute it, that wasn't a typical, way to give that drug. And we also were wondering where she pulled the med from, because that's typically not available in a lot of areas. So which Pyxis was she using? Yeah.
Really awesome thoughts. She pulled the med from an ADC in an ICU, so I think that's why she had access to the Versed and the paralytic.
So these 2 rows won't speak, so I'm speaking for us. We talked about a lot of different things, as everyone has, but one of the things we talked about is that they didn't identify it as a med error at first, like you've already mentioned, so they didn't report it right away, which is what got the hospital into some, being reviewed. And then also, we're still questioning that the ME said that it was natural causes. That makes no sense to us.
Well, the ME declined the case initially because they were told that the patient died basically from the brain bleed, so it was only uncovered later with the CMS inquiry. All right, awesome. Over here?
One of the things we brought up was possibly that since they did have the float nurse going? Did they have some sort of staffing issue there as well? You know, a lot of times it could be that it was grabbed from the Pyxis quickly. I guess that would be a provider issue. The other one for paralytics themselves, you know, a lot of times you're going to use it in rapid sequence intubation. Is it better off that it should be in just a RSI box versus actually even being in an Omnicell for it to be able to even grabbed this way? It's the appropriate indication for that.
So one thing we talked about and I guess this is a systems thing, is that obviously the drug substitution is the crux of this, but had it not been a drug substitution, is it their policy to give 2 milligrams of Versed to somebody sitting in a waiting room? Because I can't imagine that that's a safe systems practice either. So even if it had been the correct drug, was the timing and location of administration correct?
And did they think about non-medicinal approaches? I mean, as a chaplain, I'm aware that, you know, kind of there's anxiety that sometimes needs to be cared for, heard, and will, you know, so was that an option?
Great thoughts. So one of the things that we questioned was if the patient was from an ICU, why was there not a nurse monitoring the patient one-on-one, regardless of where they were sent for testing? And the other question that we had was, did the help all nurse verify the order on the MAR herself instead of just taking the bedside order that the physician had ordered the medication?
Another thing that we kind of talked about was policies at some other institutions, like having no distractions or no talking to the nurse who's pulling a medication, making sure there's signs about that so no one, even physicians, can interrupt. And the other one was like maybe having like red sticky labels or something unique about the Omnicell box that is the like paralytic agents that's very obviously different from all the other boxes in the Omnicell or drug dispensing cabinet.
Awesome. What else?
One of the things that it hasn't been mentioned yet that we thought of was what was the experience level of the nurse and why was the orientee necessarily with a free-floating nurse? Like, so why did she have that distraction, I guess?
Great. Who else?
One thing we looked at was, is it standard of care to have 2 character recognition when you're pulling out the Omnicell? Should it be more? And also, should we have meds available other than in the non-generic names?
So I'm from imaging, not nursing. And so from my point of view, I wonder why the imaging technologist didn't insist that their patient be monitored. Because we would put a monitor on anybody that's had Versed in our department. So.
Absolutely. Any other thoughts on systems factors? So you guys did an awesome job of identifying a lot of systems factors. So I would ask, with this in mind, was just culture applied to this nurse when she was charged with reckless homicide? Anyone have thoughts about that? I'm seeing a lot of no's.
My feeling is no, because as we've identified, I mean, there's 2 buckets of accountability, and everything that we've identified really are systems accountabilities. The only decision that the nurse has, or the only accountability that the nurse has, is to follow or not follow the protocols and procedures that he or she have been given. So I would say no, they did not follow a just culture.
Great. Anyone else want to add to that?
So the reason this case was such a big deal, in addition to being highly publicized, is it's a big deal anytime a healthcare provider is charged criminally. So the other one that kind of has come up recently a lot, if anybody's listened to the Dr. Death podcast, is the Christopher Dench case. But a big part of what you have to establish is intentionality. So it certainly seems like for it to be a criminal act, there has to be some degree of intentionality. It's not that there was no fault, because clearly there was fault on part of the system and on part of the providers. But you know, in terms of calling this a criminal act, that implies gross negligence or intentionality, which I'm not sure that you can prove in this case.
Great. Anyone else?
This was more of a physician issue, but who was the physician? Is it attending? Is it a resident? And why in the world are we giving Versed? Like, why that drug? I'm really curious to know who the physician was and how much experience.
Absolutely. And the physician not charged, not fired, as far as we know.
So my concern with this case, honestly, more than anything, is that I think that overall that it basically makes patients more unsafe by charging someone criminally, because this would make, I'm not saying this is right, so just don't fire me at the stake, but I think that it's more likely that people will try to hide med errors like this if they think that they are going to be charged criminally. And when we hide things, we obviously aren't fixing the issue. So.
Absolutely. That's such a key point. And, Pam is here, and I think that she would say that that's, we want to have a just culture here at Erlanger where everyone is free to report without feeling like there'll be repercussions for that. Okay. All right. Now we're going to talk about things that we've put in place at Erlanger to try to prevent this from happening here.
All right, so it was kind of interesting that I got asked to do this because something popped up a few days prior to them coming to me and asking me to present. So these are kind of safeguards we've put in place here at Erlanger since this incident occurred. So now anytime you access an Omnicell, you're going to get this screen that pops up when you try to pull any type of neuromuscular blocker. The screen over here on the left is kind of what you'll see. And to physically proceed to the next screen, you have to select the medicine and then verify it again to say you want to hit yes and to proceed on. And just from personal experience, pulling this in a rapid intubation situation, you've got to push the screen tough and look at what you're doing before you proceed on. The third screen you're going to see is verifying that you want to pull this medicine. It's going to prompt you that it is a neuromuscular blocker. Are you intending to paralyze the patient? And do you have an airway and a sedation being considered? And then you confirm your response and can pull your medicine. So 3 steps you have to go through now before you can pull any type of paralytic here at Erlanger. Something I also want to bring up because several people brought it up, and that's one thing I questioned too. When we pull any type of paralytic out of our Omnicell system, it's always in the fridge. And all of our paralytics are in an actual tackle box with a big yellow sticker on it that says paralyzing agent. I'm curious to know if Vanderbilt had anything like that would kind of alert the person pulling it that this was a paralytic, not only in a tackle box, but also the yellow sticker as well.
Okay, and then things that have been looked at from a pharmacy standpoint, we've worked together with nursing to implement the things that Colby mentioned. And, tagging on to this storage of medications, we do the best we can and we set policies in place. That doesn't always prevent wrong medicines from getting into the wrong place. I think we've all seen medications lying around when they were supposed to be stored again in the Omnicell. I've seen, paralytics or various other medications that have made it from a pocket to the wrong drawer. So it's really important that we don't bypass policies that are in place because they seem small or insignificant. Every medication policy that we set into place has a very specific reason so that things like this don't happen. And so what we did was defined the risk in this situation, looking at high-risk medication policies at Erlanger. So we've reviewed those, revised them in some places where it's appropriate, looking at both are these lists complete, and do we include high-risk medications that truly shouldn't be on this list, so that when we define a policy like this, we're including things that matter. Also, we looked at safe storage of all high-risk medications. So we reviewed those ISMP guidelines for automated dispensing cabinets and how they should be utilized to promote med safety. We've limited access to certain medications in those ADCs to areas where use would be appropriate. And so I heard a great question about, why would a paralyzing agent be in a given area if it wasn't intended for use in that area commonly? We've ensured standardized labeling of high-risk medications. Again, like Colby mentioned, it should not only prompt the user to acknowledge that a paralytic is intended for use, but also should be a second check when that provider opens up a tackle box to obtain a medication. And then requirement for that person administering the med to confirm appropriateness of a high-risk medication when they're pulling it from the cabinet. And in terms of actual administration of the medication, we have vecuronium listed now as midazolam to avoid that confusion with a look-alike, sound-alike drug. And medication barcode scanning is required prior to drug administration.
So here at Erlanger, we have a moderate sedation policy. So they consider moderate sedation or analgesia any IV medication given. That's a sedative, hypnotic. IV Ativan is considered moderate sedation here that you give for procedure or imaging. So Colby talked a little bit about this, what are requirements here. So a patient has to be evaluated immediately by a provider prior to the procedure. But also here, they have to be credentialed for moderate sedation. I think that's a big thing here. That's the difference. Somebody asked, was this a resident or an attending over there that had ordered this medication? Any sedated patient should not be left alone during or immediately after sedation. And there has to be a competent monitoring assistant continuously in attendance during the procedure. Also, they have to do the timeout before they give the administration, and then even they have a minimum monitoring where you have to assess vitals and level of consciousness every 5 minutes as well as being placed on telemetry. So I think it's safe to say a lot of these things weren't done in this case, but this is something that Erlanger does have here in place. So the question is, are there any remaining vulnerabilities here at Erlanger that you can think of? These are the things that we've addressed and changed here. And are there anything that you can think of that, we could try to make it a better system here?
So if you want to get back with your groups for just a couple of minutes and see if there's any, if there's anything you'd like to bring forward to the group as a remaining vulnerability.
That's what I said. No, for Atlantic procedure. So is it only going to be for that? How are you? You know what I'm saying? Like, we need to follow. We give it for like a time 50. Hey, question. We give Ativan all the time for.
I said vecuronium listed as midazolam.
All right, anyone want to share?
I know you got stuff.
Yeah.
She said.
What? I think you should talk on that one. Go. Okay. Okay. We had a couple of things here. one of them being staffing for, if this were to have happened here at our hospital and you had to take one nurse away from the ICU to go administer medications for a patient, that leaves the other patients vulnerable because the higher ratios. But the other thing that we found was that here at Erlanger, we don't have scanners in those outpatient areas. And so like anesthesia, when they do anesthesia and MRI, they document on paper record. And so if we were to take a medication, we would not be able to scan the patient and scan the medication to get an override error. So that might be something that we can look into.
We look into that.
I have a quick question. I'm
Awesome,
sorry.
thank you.
Before in the pharmacy piece, the last pharmacy piece of the presentation, you said Ativan at the beginning. Did you mean Versed? You meant Versed. Okay, all right. Debate solved.
So on the moderate sedation policy, it says anything given IV, whether it's a sedative or a narcotic, would be considered moderate sedation if it's given to facilitate a procedure. And we're considering imaging studies to be procedures.
A lot of the floor nurses, when they do that, they're not moderate credentialed for moderate sedation, so they have to be.
So my concern is that that is common for a patient to get some sort of Ativan before a procedure, and your general acute care nurses are not going to be moderate sedation credentialed to give that medication.
I think it's something that's going to have to be looked at further and potentially be a culture change. I know that it's been addressed within the residency program. We've said it needs, if you're giving something to facilitate imaging, it needs to be oral, or you need special monitoring. I think there are some lines, because what if it's for anxiety and that's occurring an hour before? There's some gray, but I don't think we should be sending someone down with an IV sedative to radiology and having a patient unmonitored.
Okay, I don't know if there's actually a policy in place at Erlanger, but there are no signs or anything talking about like reminding people not to, be chatting while they're at the Omnicell pulling things. I think just having signs or something reminding people that you're taking out medications, you should be paying attention to that, not talking. I don't know, just having a reminder there. I don't know if that's already in the policy anywhere.
I think that's a great thought, like quiet zone. I think some hospitals have that, because I think distraction definitely played a role here. It's a great thought. Anyone else?
So just talking about institutional vulnerabilities, one thing that we were talking about that I think is an institution-wide issue is that we do have such issues with overcrowding. So on the inpatient side, I have been in a position as a provider where you don't want somebody to lose their spot in MRI, and you're getting this frantic phone call where they're saying, oh, well, they can't tolerate it, they're going to have to send them back up, and they'll go back to the end of the 50% line. So I think, anything that we can do to deal with overcrowding to maybe make that a little bit safer, because you're not given a window where you're saying, hey, well, I'll come down, in 10 minutes and evaluate that patient. You're not really given that opportunity. They're going to go back to their room, and we'll figure out when we can get them down next. So I think that's, from an institutional standpoint, a vulnerability we have on a few fronts that carries over into this imaging as well.
And I think while we don't have an easy answer for overcrowding, I think that we need to do a better job as providers of screening patients for claustrophobia or agitation, making sure they're ready for the scan, and maybe on the nursing side, screening them again before you let them go down. And if a patient's agitated, probably Maureen would say, don't send them down. Address it before.
Filling out that screening form that specifically asks that question. So that nursing screening form that we love that you fill out before they come down has the question about claustrophobia, and that's exactly why it's so key. Is so one, we monitor them correctly when they do come down, or that we know they've had Ativan or something stronger. Just communication in getting the patient done the first time is really key.
In this case, there was definitely a rush. There was a phone call of, you've got to send someone, give this med now, we're sending the patient back, that kind of feeling, and that does happen here, as Dr. Hyde mentioned. So definitely the pre-screening might help prevent this kind of thing from happening. All right, it's 1:30. I think we have another comment.
And sorry, I just wanted to clarify one thing. All neuromuscular blockers are not in tackle boxes, and they're not all refrigerated. Vecuronium is actually not supposed to be refrigerated, and it is kept in the cabinet. The way that you know that it's a neuromuscular blocker is the fact that we put it in baggies, and it has red labels and stickers and stuff on it, kind of screaming, hey, look at me, I'm different. But I just wanted to make that clarification because I don't want anybody to get back to their area and be like, ours aren't all in tackle boxes. So just clarification. And then any that you pull out of the cabinet, though, should show up with this screenshots that Colby showed where you have to go through the steps.
I also think that and Kayla already said this, but that we're under-reporting, and I think this is going to encourage that under-reporting. And I know we're working on a just cause, but can we celebrate people reporting in some way? I've been at conferences where they actually asked the residents and the nurses to report, and they quadrupled their reporting. A lot of times we don't know there's been an incident because no one reports it, and this makes me more fearful that nurses are not going to report things.
It's a great point. I think that we're trying to really encourage reporting and encourage great catches. I know that at QOC there's a great catch award, and I think Pam might want to say more about that.
Sure. I agree. I feel like we're underreporting, but I have to say in the past 18 months, we've doubled the number of events that we are reporting. So we are heading in the right direction, and that's thanks to everyone in this room. But we have additional opportunity, for sure.
Wonderful. All right, thank you all so much for coming. Thank you to our presenters.